Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. Hi everybody, welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
So today we're going to be talking about a fairly recent paper, British Journal of Surgery, Surgical Considerations for TIL Therapy in Melanoma, results from a randomized phase 3 trial. Just to say quickly that relates to the Rohan TIL versus IPI trial, which was NEJM December the 7th, 2022. But before we get to that, Sapna, what are you watching at the moment? What can you recommend?
The Dallas Cowboys documentary on Netflix. The America's Team, The Gambler and His Cowboys, I think is what it's called. I like the F1 Drive to Survive series on Netflix. It's like a reality documentary. And then The Bridge season 2. The noir
original Bridge, just for the record, right?
I forget what they call that genre, that they said that like this was the origin of like Danish, not film noir, but it's that sort of like
Scandi noir.
Scandi. Yeah.
Scandi noir. Yeah. Okay.
Yeah, that was your recommendation.
Yeah, let's not digress. I reckon we've digressed into that before, actually. But amazing.
What are your viewing recommendations?
Just at the moment, Brassic. Yeah, which isn't everyone's cup of tea. Season 7's just about to come out. And some South Park, sprinkled with a touch of South Park, actually, as well.
I didn't realize you guys are South Park watchers.
Yeah,
like
come
regular?
on. No, not regular, but you know, there's a time and a place, isn't there? And you can always go back to it as well. It repays rewatching. I think you can say that. And people are writing a lot about South Park at the moment as well, in terms of
oh really?
In terms of the current themes and stuff. But that would be a digression as well.
I didn't realize they had anything current. The last one I obviously saw Ozempic. I saw there was something, but I hadn't seen anything like from the last year or two. But can't wait. Yeah,
there's quite a lot of Trump stuff actually. Anyway, so let's maybe say that again.
South Park is the gift that keeps on giving. So you've gone extremely pixelated on my end, which now you're back. Let me just check my internet here. Looks okay. I'm just going to close my email for good measure. Okay, continue. I'm listening.
No, so maybe we should get down to it. So, British Journal of Surgery, the first author, Lieselotte Tass, from NKI, and then the senior author is Winan J. Van Hout. Quick shout out to Winan, who used to be a surgeon with us, who's also at NKI, and then sort of loads of other friends and colleagues who are authors on this, as you might imagine, in the Netherlands and Australia, Inga Marie and colleagues, Marco Donia in Copenhagen as well. So those, that's the authorship team. Do you want to maybe go over to you now, so you could just say a bit about the background?
Well, you mentioned this is a description of the harvest from the TIL arm of TIL versus ipilimumab in, this would have been PD-1 refractory melanoma patients, metastatic melanoma patients. And the reason it's relevant is we've not actually really seen a proper publication on describing the surgical harvest, or, what's sometimes referred to as the tumor tissue procurement step. And so these guys look at their, 84 patients who got randomized to the TIL arm, and they described the surgeries, the success rate of first TIL manufacturing, the percentage of patients who needed a second harvest. And then they get a little granular for us, and they describe the difference in number. They basically describe if you resected one tumor versus multiple tumors, the size of the tumors, and then maybe importantly, the anatomic selection. Because in the second line and beyond, it's not that we have solitary mets that we're treating, right? By definition, you need something to resect and something to leave behind. So they describe the anatomic location. And this is interesting because we will have a choice of anatomic site of harvest, and this paper might start to guide us a little bit, though I think there's still some unanswered questions here. So that's kind of the background.
Yeah, maybe just to enlarge that slightly and sort of hammer it home a little bit. You guys got this in clinic at the moment. You've got reimbursement availability of lifileucel, and there'll be other places actually ex-US as well, not necessarily with lifileucel, but other cellular therapy products that people are using. So actually practically in clinic and in discussion with surgeons and the rest of the team, we need to, you guys particularly need to make decisions about this every day. So I actually think from that perspective, it's really valuable information. So congrats to the team really for publishing it. So should we get into the detail a little bit?
Yep. So 84 patients randomized to TIL. 80 went on to actually get TIL, and they have a concert diagram explaining the 4 who didn't. So let's use 80 as our denominator. 80 patients went on to TIL. How many of those 80 surgeries, cool, were successful? Essentially, 10 patients needed a reharvest. So 70 out of 80. I think if I'm doing the math right, then that's a 12.5% first harvest failure rate. And we don't have any benchmark for this. So that's neither good nor bad. That's just the number that it is. 12.5% needed another surgery. They didn't have successful ex vivo expansion. They call it a failure of TMP, investigational manufacturing product. But we don't know how they necessarily define failure, because in the Steve Rosenberg lab at the NCI, failure was defined as not being able to expand to say 40 to 50 million in that first expansion, which you usually look between like days 7 and 14 for that first look. So 40 to 50 million, because if you couldn't get to 40 or 50 million, then on that back half, that quote unquote rapid expansion phase, you weren't going to top over $1 billion. And $1 billion to infuse was always felt like the minimum. In fact, in the US, the lifileucel label says it needs to be 7.5 billion in order to be infusible. So anything that, if you get $1 billion or 2 billion, that's considered out of specification. That's considered out of the FDA range. And so then it's considered like an investigational product practically. So, but the old Rosenberg number, success would have been 40 or 50 million at that first look. So I'm not sure how they're calling failure here. Are they saying they didn't get to 40 or 50 million at the first look? Are they saying by week 1 or 2, it was some other threshold they were looking at? Or did they go all the way to week 3 and not get to top $1 billion? The reason I don't think it's that last definition is they tell you the time interval, the median time to the second harvest in those 10 patients that needed a second was 21.5 days. So you wouldn't have been able to get somebody to harvest half a day later after waiting the full 21-day manufacturing period. So they have some early definition of success. I'm not sure I read that here. It's neither here nor there, but that's just to explain, there's some early look. And you get that with the standard of care product. You get feedback from the company or from your lab, each week if things are on track. So that's the failure rate.
Yeah, maybe.
Yeah.
I was just going to pick up one quick thing as well before we sort of get into the figures, which is the sort of surgical aspects of this, because that is a sort of reasonably important question as well. And they report on that. And the bottom line, I think, is that in terms of surgical morbidity, I don't think there's anything really out of the ordinary here. And in the interest of avoiding a fact check, I've looked up the Clavian-Dindo classification, which they actually mention
Okay, say that
in the
one more
abstract,
time.
which is a Clavian-Dindo. Dindo. Have I got that right?
My ear was tickling for a second. Okay, I hear you.
Okay. Hopefully that's now stopped. Anyway, so actually, the renal surgeons use this as well, so it's quite widely used. And just to read from the results, the complications, if you like, 17% of operations 1-7, mostly mild Clavian/Dindo or hyphen, grade 1/2 complications, and one Clavian-Dindo grade 3 complication. So then, of course, the question becomes, what does that mean? And I will now reveal that. So grade 1 is any deviation. Yeah, well, okay. Grade 1, just to do it from the top, any deviation from normal post-op course without the need for intervention, effectively, such as endoscopic, surgical, pharmacological, blah, blah, blah. Grade 2, requiring pharmacological treatment with drugs, other than some of the ones that are allowed for grade 1, which is stuff like antiemetics, antipyretics, analgesics. And you could have a blood transfusion under that heading, or TPN. Grade 3, requiring surgical, endoscopic, or radiological intervention. And then the 3A is intervention not under general anesthesia, 3B, intervention under general anesthesia. So I think that sort of answers that. For the record, grade 4 is organ system dysfunction, and grade 5 is death. So probably, I don't think, and we're physicians, obviously not too much more to say about that, but I think it's a sort of maybe important general point for people who are considering this in their tumour boards and multidisciplinary meetings. What does the surgical experience look like, as it were?
Okay, table 1. Go for it.
Table 1.
Unless you want me to.
No, let's get table 1 up. Okay, so this is details of all lesions that were resected. It's quite a busy table, actually, isn't it? And they divide it up along the column: successful TIL manufacture after first operation, 72. Failed after first operation, 11. Successful, this is the third column, TIL after second operation, that's 10 patients, and then they've got all operations at the end. So I guess you maybe see from this, if you look at number of lesions resected, most of the time it's 1, but there are a few, 2, and then not many that are either 3, 4, or 5. Size of lesion, they're dividing up less than 2, 2 to 4, greater than 4 centimeters. And again, I guess most of it's ending up being 2 to 4 centimeters with a few either side. Site of metastasectomy is what they say, or resection. So lymph node, at least in the first surgery, 44%, subcutaneous 30%, other round about 20%. That changes then with subsequent surgery, fewer lymph nodes, more subcutaneous, more other. Time in hospital, type of anesthesia, steroid use perioperatively, surgical complications, margins. I guess the thing that you picked up was the steroid use perioperatively, which felt like it was quite high. So 40% first operation, 60% second operation. And we couldn't, I think you and I, quite work out why that was. And then I went back and looked at the protocol.
Wait, hang on.
I think, go on.
Where do you see 60% second operation?
64% steroid use perioperatively. You seeing that? 7 patients.
That's for the ones who failed.
Correct. Yeah, exactly.
Okay.
But
you're saying
just
the
to make
proportion of people who failed. I got you. Okay.
Yeah,
second operation.
Yeah, and I think we thought that the fact that those numbers were so high was because anyone who was on any significant doses of steroid per protocol, i.e. over 10 milligrams of prednisolone or equivalent, wouldn't have been eligible. So maybe there's as many people as that on those doses of steroids. So if they're on the end of a steroid with previous tox or something like that, and maybe a little bit of adrenal insufficiency, but I guess we don't really know. We're speculating on that. And then the other thing was the margin positive resection, which was 17% actually, the first operation. And again, I guess we sort of thought maybe that was a little on the high side in the context of surgical procedures that we would, let's say, otherwise be used to and familiar with. But maybe just to deal with that quickly now, maybe in this situation, actually getting an R0 resection, whilst not trivial, maybe isn't one of the overriding goals of this type of surgery. What do you think?
Yeah, I think that's right. I mean, it's not leading to a higher failure rate. It's just, in fact, it's a pretty low failure rate. So they basically say the surgeons who didn't want to kind of risk damage to a vessel or nerve left macroscopic behind. That's okay. In this case, it didn't lead to rapid recurrence or lesion regrowth in that area. So I think that's okay.
Yeah. So maybe if we look at table 2, go on, sorry.
Okay, we're cutting in a second edition of this paper. Hang on, is your email closed? It's pixelating a tiny bit. Okay, so we're just going to deal with it. And we're going to jump back into this surgical TIL paper starting from the tables and figures. So table 1, surgical details. Do you say details or details?
Details. Do you say details?
Yeah, if you're kind of a poshy American, you might say details.
Really?
Of all lesions that were resected. And so, is there anything you take away here? There's a couple of things I get, but I get more from the figures.
No, so you go.
This table basically tells you about number of lesions resected. So this is metastatic melanoma, where it's not that we have oligometastatic disease. In fact, by definition, you need more than one tumor, right? Well, it's not that you have solitary metastasis, I suppose. And so the question is, do you resect one of these or multiple of these tumors? Is more better? They break it down by size of the resection specimen, the site, anatomic site, and they do something nice here that we have not seen in the Iovance data. So I like that they break it down. They separate lymph node and subcutaneous. So they don't just say lymph node / subcutaneous, they really separate lymph node and subcutaneous. You know, as one of our international colleagues will say, lymph nodes are the schools for T cells. And so they have a different, quantity of T cells often than a subcutaneous met. They break it down by anesthesia. I didn't glean too much there. Steroid use perioperatively, closure method, margins, and clavio-dindo complications. But what I get from there is resecting one lesion is best. So then they say, how successful was the TIL? After that first operation, the sort of inverse, which is how much failed after that first operation. So how much expansion of TIL failed. And then they talk about the few patients that underwent a second operation, but for the purposes of this, I think we can skip that. Essentially, what I take away is resecting one is enough, and the optimal size of that one lesion should be between 2 and 4 centimeters. So less than 2 centimeters, you have a less robust success rate. And then similarly, their percentages here are percentages of the whole, not percentages of success, just FYI. And then too large a lesion, what I've learned from, for example, Iovance, when you submit too large of a metastatectomy, they cannot pull out the T cells and ex vivo expand that entire sample. They can't 96 well plate an 8 centimeter tumor, for example. But so there is an optimal size. You don't want it too small because you want enough T cells in each well to expand. You don't want it too large because they're just having to check some of that tumor and, maybe or maybe not, they got the most TIL enriched site. And then lymph node is the best. So a solitary resection, 2 to 4 centimeters in size of a lymph node anatomic site is the best. That's what I gleaned from that. And that sort of mirrors what you see in a subsequent figure. Table 2, yeah, go on.
I was going no, maybe, yeah, I mean, all agreed. And I guess maybe the only other thing I'll pull out of table 1 is the steroid use bit. To say that if you look at that, it's sort of just under halfway down. Steroid use perioperatively, yes, no. It doesn't look like in the people where you are using steroids, it necessarily leads to failure. So I think practically that might be worthwhile knowing. And
Here's a question I have for you.
Okay.
In those 72 patients, all I get from that steroid use perioperatively in that first column, successful manufacturing, is that they are saying, oh, you know what this is? This is on 72 they were able to successfully manufacture. So this doesn't tell you on the 12 people they couldn't manufacture, but basically exactly like you said, half of those patients that they could successfully manufacture use steroids perioperatively, half did not. Doesn't necessarily tell us much about the dose or the duration.
Yeah, and that little symbol, do you know the name of it? It's kind of like
paragraph.
Yeah, is that what it's called?
It looks like a reverse paragraph. The paragraph goes the other way.
Let's call it a reverse paragraph. So that the footnote, low dose corticosteroid use perioperatively, blah blah blah, that was not temporarily omitted. So dose is obviously going to be an important consideration, but like you said, I don't think you can really say too much about that. I'm going to cough. Let me go onto mute.
Gesundheit? I don't know what we say for a cough.
Yeah, I'm okay, I think. Right, shall we move on?
Yeah. Table 2 is a bit more of this number of lesion size and location. And I think it's a little more statistical here. They give you some pure p-value and odds ratio stuff here. But again, unless I'm reading it wrong, to me, it seems like failure rate is a little bit higher when you go beyond one resected lesion. Failure rate's a little bit higher if you're too small. Failure rate's a little bit higher if you're subcutaneous. Now that really jumped out at us. The odds ratio for failure was like 12x with an interesting p-value. I say interesting, I mean, it's 0.037. And that feels really interesting because if lymph node is your reference point for successful TIL harvest, by harvesting a subcutaneous, that failure rate really does seem higher than a lymph node. Granted, all sites are higher than a lymph node failure rate, but that's what I gleaned from table 2. And then the figures might be a little bit easier for you to review on the fly if you want to look at figures 2 and 3.
Yeah, so 2A is failure as well. Yeah, I think it is a bit easier. It jumps out more, doesn't it? Don't you think?
Mm-hmm.
In the figures, and that's a number of lesion size and site, just as you've said, in fact. And then B is number, size, and site of metastasectomy. And again, this is now graphing response. And it's overall response and response over 6 months. So, I mainly think this is a kind of an easier way to say it than in the tables, actually. I don't know. Are you getting anything else?
Doesn't it jump out at you the same, that it's basically, it zeroes in on a single tumor, 2 to 4 centimeters in size, prefer it to be a lymph node.
Yeah.
It gives you the lowest failure rate, and a reasonable response and or a response lasting greater than 6 months.
Yeah.
Yeah. And, it's the highest denominator. It's worth mentioning. I think it's the highest denominator. Let me go back to table 1. It is the highest denominator. Yeah. Okay. And then figure 3, similarly, now you have some pie charts that show you for a lymph node, you fail to expand rarely. Of those lymph nodes that expanded, you were responding in half of those patients and non-responding in half of those patients. And that seems to be the best response we see. There is this other visceral, but with a lot of caveats that that's a very heterogeneous group of 19 patients. So you're talking about visceral metastasis, pulmonary metastasis, muscular metastasis, peritoneal, and those are all different. So, the response rate is 53% there, but the failure rate is a little bit higher. It's all small numbers though, but I glean the same thing here. I mean, the real thing that I glean is harvesting more than one lesion doesn't get you any benefit here. Look at that down at the very bottom, figure 3C. Harvesting more than one unsuccessful ex vivo expansion is 14%, and importantly, a lot of non-response there. And again, picture how they're putting these in wells, like, are you combining those multiple tumor sites? Is each tumor site getting their own 96 well plate? I think some of this we don't totally know, that we could ask the authors. And then getting too small a tumor is not great. So again, figure 3 to me drills down on a lymph node, preferably a singular lymph node, 2 to 4 centimeters in size.
Yeah, agreed. I mean, go on.
Well, I was just going to say, now we've infused 17 or 18 patients here in Colorado. This has changed how I think about being a little more heavy-handed about directing the surgeon, because that soft tissue metastasis might be the easiest to get to. It might be a gluteal metastasis, as it were, or abdominal or something, but I might try to direct them towards a lymph node metastasis if we have one, 2 to 4 centimeters, based on this data. And I have, seen the Iovance data that combines soft tissue and lymph node, and I don't know where to put that data, because this data from the Netherlands feels a lot more granular, separating those groups. And if I don't see that data coming from Iovance, then I will make a decision to go after lymph nodes, which may mean holding on to a patient a little bit longer because their lymph node is not yet big enough, et cetera, et cetera, et cetera. Anyway, go on.
No, I mean, I agree. And I think these are important practical considerations when you're meeting patients for the first time and talking to your colleagues. And sometimes this whole business about waiting for things to get a little bit bigger actually is quite important. And of course the patients are itching to get treatment as soon as possible, which we all would be, and we understand. But sometimes if you say, well, actually, this is going to be the best thing, we probably want to wait a little bit. There's no harm in waiting a little bit, and actually, if anything, that's going to give us the best shot at making the therapy. So I think it's a nice paper, and this is clinically important information. So congrats to the authors.
Big time. I think this has been the type of paper I think the surgeons have been waiting for also. But I think the implications for us medical oncologists are also quite big, because, it does help us. It helps inform who these kind of optimal patients are that may have.
Yeah, I mean, we've got these patients in our clinic actually before we even get to the point that we're thinking about TILs. And I think that's useful as well. You kind of flag up earlier on, oh, actually, this might be someone who's suitable. This might be the area of disease that we're thinking about. And then when they get to the point where they need TILs, you sort of, in your head at least, got a plan, and you maybe even talk to the patient about the plan in advance. So I think it's useful information. And actually, I'd recommend it to medical oncologists. I think I said to you when I was in Sao Paulo recently at a meeting, and I think I was doing a TILs talk, and I think they hadn't seen this paper, and I actually recommended it to the people there to help them in clinic.
There are maybe 3 other things about TIL that sort of still linger in my head. I still want to know the dose a patient is getting. What is the TIL dose a patient is getting? With our commercial product, you don't get that. You don't know the dose they're getting. You get a range of, 1 billion to 99 billion, something like that, but you don't actually know the dose they're receiving. That's a pity, I think. So knowing the dose, and if TIL response is actually dose responsive, would be helpful. And then knowing, are these TIL trafficking to tumor sites? That's a big deal. I would love to know, is it getting into the bone metastases? Is it getting into the liver as easily as it's getting into the lung and the spleen, et cetera? So trafficking of TIL, and then of course persistence. It's always nice to know if these cells are in persistence, but we can only do that if the company did that on trial, because they're the only ones that know the phenotype of the product they infused. So
yeah, all good points.
CD4 to CD8 ratio. I love all that stuff.
Yeah.
Cool. Well, thanks for finishing up this paper.
Okay.
Okay.
Bye.
Bye.